So let's go ahead and get started this morning. Thank you all for being here. I will introduce our speaker in just a moment, but wanted to have a couple of announcements. On the February 5th, we're going to have a special grand rounds. Paige Hector will be giving a discussion about transforming relationships with compassionate communication. It will be an hour-and-a-half sort of workshop. And the idea is that, you know, in this world that seems to be increasingly sort of contentious, she'll help us with some skills to be the leaders in compassionate communication. So I'm really looking forward to it, and I hope you are too. Then our next journal club will be on the 12th of February, and we have Kristen Allen and Hilary Lum presenting there. Following today's grand rounds, you will get an email with a link to the recording of today's presentation. Also included in the email will be a link to your online evaluation, and please submit any questions in the chat or Q&A boxes during the presentation. So I'm really pleased to introduce a friend, Heidi Wald, this morning. Dr. Wald is a board-certified geriatrician and physician leader serving as Chief Quality Officer at Denver Health. She's a visiting associate professor of medicine at the University of Colorado, and she leads systematic efforts to advance safe, reliable, and equitable care for all Denver residents. She was previously the Chief Quality and Safety Officer at Intermountain Health, where she oversaw quality, patient safety, experience, and equity across 32 hospitals and more than 400 clinics across 5 states. During her tenure at Intermountain, she was named, or they were named, as top large healthcare system in the United States. From 2007 to 2018, Dr. Wald served on the faculty of University of Colorado, and she was vice chair for quality in the Department of Medicine. She's received medical staff leadership awards and authored over 60 peer-reviewed publications that are all focused on patient safety and quality of care for older adults. She earned her medical degree from Harvard Medical School, completed residency at the Hospital of the University of Pennsylvania, and pursued geriatric medicine fellowships and a master's in public health at the University of Colorado. In 2009, she was the Atlantic Philanthropies Health and Aging Policy Fellow. So lots of wonderful training and bringing her quality expertise to us this morning. So please welcome Dr. Wald.
If I stand here, can they see me on the? They can see me. Okay, great. All right, I don't want to be behind the podium. And the clicker. Is there a clicker that I can use that's not attached, like a remote clicker? Do you have one?
You're going to walk around?
Yeah, sorry. I like to walk around a little bit.
The camera.
Safe mobility. If I do not trip, this will be a positive experience.
Forwards and backwards.
Awesome, thank you. All right. Well, good morning, everyone. It's really just a pleasure to be here. As I was here many years ago, but it has been 8 years since I was faculty at the university, and went on a little bit of a journey, and just a pleasure to be back. I also want to thank Carrie, and the team for reaching out about grand rounds, because I guess I'll say I have mixed feelings about it. I was like, I just got to Denver Health. I can't do it in November. Let's push it back to January. There'll be less going on in January. That's not true. But I haven't given a grand rounds in probably 10 years, 8 to 10 years. And this really gave me an opportunity. I have objectives up there, but it really gave me an opportunity to think about the threads that have pulled through my career, which has been really nice and a little therapeutic. And, also really marrying my two passions with geriatrics and patient safety, and thinking about how those have interacted and influenced me over time. These are my objectives. To trace the evolution of hazards of hospitalization, that concept that was really popular when I was training, and the now newer approach to age-friendly care, I would say, to understand and apply patient safety concepts as they inform geriatric medicine. That was that I mentioned a minute ago, and to understand safe mobility as foundational to resilience, in geriatric medicine and learn how one health system, and that was when I was at SCL Health, which then became part of Intermountain, advanced a safe mobility agenda. I did invite some of my Intermountain colleagues. I don't know if they were able to make it, but also some of my new Denver Health colleagues. So I used to start a lot of my talks with this case. This is a case. So I used to be co-director of the ACE service on the 12th floor, and with Dr. Kumbler, and we set up this really nice model of care, which I'll talk about a little bit in a moment. But I used to talk about this patient, and this is kind of loosely based on a real case where a gentleman came in with CHF, and he got some meds that maybe he shouldn't have gotten, or shouldn't have gotten in the right timing at that timing. And so with Lasix on board and then a sleeper, he kind of tries to get up to toilet, and he urinates and slips and falls and breaks his hip, right? And sadly, then he had a Foley, then he got delirium, then he got Haldol. You know how it goes, right? I don't know, this sounds very echoey. Is it echoing for you all? If we could turn it down a little bit. And bad things started to happen. He had that cascade of disability, delirium, a pressure ulcer. Then they, tried to get the Foley out, et cetera. It just didn't go well for him. He ended up with a prolonged SNF stay and progressive functional decline, and he died in SNF a couple months later. So despite the fact that he had, he came in for one thing, and we didn't really help him, right? And it was an unfortunate outcome. And this was literally pulled from old talks that I gave. What should have been done differently? Should we have thought more about our fall prevention strategies? Should we have figured out a better way? Oh, that is a little better, I think. A better way to promote sleep. Could we have done some time toileting, right, where we prompted him to toilet? Could we have done better review of the meds and thought about that, or should we done a little bit of all of it, right? And so just to tee up, always useful to start with a case. So, and we all know, and this is not news to this room, and this is a, like old headline. Actually, this is 2016. I have older headlines too, but so newsflash, right? Elderly hospital patients arrive sick, often leave disabled. This is from Kaiser Foundation newsletter that they put out. And so again, we aren't necessarily helping our patients when we bring them in for care. So, and I put this up. This is one of my favorite pictures, and I found this somewhere. It was from a newspaper article, but now Carrie tells me I could have ChatGPT generate for me, give me a picture of a hospitalized older patient who's, under chair arrest, right? And I love this term, but on the ACE, we used to do this too, right? Like sit them down, and they're not actually restrained, but they're kind of in the big, recliner, maybe a little bit back, surrounded by all of the soft stuff that you never put in a baby's crib, right? Like to prop them in different ways. And then the tray table is basically a restraint, right? The tray table is preventing this person from getting up and walking around. Old data here from Cynthia Brown, who's done amazing work in this space, but hospitalized elders at that time, she did a study less than 1 hour a day, even upright, not even out of bed, but upright. So really, we're failing our patients. And I remember a couple of patients within a short time frame in, on the ACE, I remember them saying, because we're so worried about fall prevention. So we want to do no harm. So we're going to put them under chair arrest. And I remember a couple of patients saying to me, I'm getting weaker while I'm here. And now that I have, elderly parents myself, I could just see my mother. If she were stuck like that and not doing her usual ADLs, like how could she already has like this much muscle mass left, right? And so how how quickly would she decline? And that just broke my heart that on the ACE unit, right here, where we thought we were doing the best, people were saying, no, you're making me worse, right? So it kind of horrible. This is more data. This is largely from Ken Kavinsky and Tom Gill, also really luminaries in geriatric medicine. They described hospitalization-associated disability. And these longitudinal studies that when elders lose mobility or other function, 50% of the time, or 50% of that loss is in the context of a hospitalization. So it's like this step change for people during their healthcare trajectory when they're hospitalized. And then obviously, many are discharged with a new impairment of daily living. So 30% of hospitalized adults have this hospitalization-associated disability, and the outcomes of that at 1 year are devastating. 40% are deceased at 1 year, right? 30% have recovered, and the other 29% are disabled, right? So it's crazy, a predictor of mortality, right? So anyway, just to set the stage there, that you guys may recall, or some of you may recall, that I was like the catheter-associated researcher, and we'll get to that a little bit. But I've always been really intrigued by this model. So this was published in like 1994, 93, Annals of Internal Medicine. This is a guy named Morton Creditor, I think also the early in the geriatrics movement. And I just kind of love it because it's so complicated, right? Or complex, and we'll talk about that in a minute. But if you can't quite tell, at the top there is this patient laying in a bed, horizontal in the bed. And they have all the sequelae of usual aging, right? All the physiologic changes that we know about as you age. But then they have all of these things that go along with bed rest and hospitalization. So, you're in a high bed with bed rails, you're immobilized. Because you're not moving, you have decreases in plasma volume. So you have real physiologic changes just from being immobile. Accelerated bone loss, pulmonary changes. You've got then obviously the sensory deprivation, right? We know, you don't have your glasses, you don't have your dentures, you can't hear, you don't have your hearing aids. You're in a dark room. There was a period of time when the new ED first opened. So it's not the new ED anymore, but the big, beautiful, humongous ED first opened. And we used the old ED, which was pretty small and dark, as an overflow unit. And we used to end up with ACE patients in this overflow unit, so the first floor of the main hospital building. And I used to call them delirium rooms. Like they were like these tiny little bays with a TV blaring and big fluorescent lights and no windows. And they would close the door because there's so much noise in the hallways because it was like an old ED anyway. But, so the sensory deprivation is real. And then we tether them with an IV or a Foley or whatever. And then, we schlep them around on the bed, which is not great for their skin. And other things. And what occurs then is this cascade of interacting badness. I'll come back, we'll come back to this a couple of times over the talk. But right, so these were the things that I was interested in about the hazards of hospitalization, right? You can see falls, you can see delirium, you can see the catheter and then the infection, and you can see the pressure ulcer. So these are just some of the sequelae that occur with higher frequency because of the usual aging, and then on top of that, the hazards of that bed rest and hospitalization. So and so that's where for many years I focused on, okay, let me just focus on one problem. Let's look at catheter-associated UTI. Let's look at Foley catheter use. And I had, I don't know, many years of productive scholarship just focused on this vertical here. The functional incontinence, so we get a catheter, so we get an infection. This is related to, I'm not going to go through all of that work that I did, but this is related to mobility, right? Sanjay Saint, who I think is still at Michigan, is very good at coining these funny terms. This was one of his ones that I love, the 1-point restraint, right? That the Foley catheter, had real impact on mobility, basically. False delirium, immobility, in addition to all of the local problems in the urinary tract that a Foley catheter could cause. So it isn't totally unrelated. But I did spend a lot of time kind of working on that one problem, that one vertical. And I published something many years ago now about lessons that I learned from really working in the infection prevention space. And I might mention that Sanjay Saint was Vineet Chopra's mentor at Michigan. They wrote a book together recently on mentoring, but that's how I know the department chair, because we used to show up at ID meetings together. We're both hospitalists. And so the community is small, and we go way back there. So lessons learned that I learned from infection prevention. The infection control paradigm we know it pretty well, right? It's in every hospital. It's an important piece of what regulatory requirements in hospitals. And so this is what we learned, I think, from that paradigm, that, you could develop bundles of evidence-based practices that you could try and apply reliably to every patient. That idea of, every patient gets the same thing every time, to decrease risk of infection. In the case of Foley catheter, the key was getting the Foley out, right? How do we reduce catheter days? That you had, focused on zero preventable harm. You couldn't always get there, but that you had to say, this is not acceptable as part of, our practice. We can't just say, they had a Foley in, they had a central line. And that was kind of the way it was when, I remember when I was training in residency, we rolled out our first initiative about central line insertion when I was a resident. I was at University of Pennsylvania. And like the idea that you would gown and glove to put in a central line was brand new, right? So there was a period of time when, we kind of just accepted infections because we had to use a catheter and we had to use the central line. They really did great work with surveillance, right? We all know we can count line days, we can count antibiotic days, we can count infections based on standard criteria. They were always investing in prevention research, and then, focused on the ones that had the highest burden, greatest preventability. And so I think the question was, could you ever do that with hospital hazards of hospitalization of the elderly? Were we ever going to track delirium according to standard definitions? Were we ever going to, kind of really get serious about these individual conditions? I put this picture up here to show, this is Denver Health data that I have just become familiar with in the last 6 months since I've been at Denver Health. Thank you. This is spectacular. So these are all of their infections. They started an initiative back in 2015. Tom McKenzie was the chief quality officer. And they said, we're going to create bundles of evidence-based practices for CAUTI, CLABSI, C. diff, HAPI. HAPI is the one that's not an actual infection. MRSA, MSSA, and SSIs. We're going to create bundles, and we are going to drive these to zero. And look what they did over a decade of work. I mean, they were even surprised last year. We ended 2025 lower than we've ever been. We've continued to drive down infections using this paradigm. So there were impressive results here, and this was seen all over the country. And I would note that, they kind of stabilized over the pandemic, right? But they didn't, they went up a little, they bobbled around, they were didn't have that continued drop, but they didn't look awful during the pandemic, right? When we were, and that was a period of time where we, CMS was like, oh, you don't have to submit infections, you know, because we know it's going to be a mess during the pandemic. A lot of organizations backslid with infections during the pandemic. It's well documented in the literature, but Denver Health did amazing work over this period of time. So I've just been impressed by that, and I've been showing this graph everywhere. Now, we've just had a little blip of SSIs, and so we got to drive it down. But in general, this paradigm has been shown to work. But one of the things that always came up was like, well, you know, we know you should take the foliate, and we know you should clean this way, and we know you should do surveillance, but like, do we know that everything in the bundle needs to work to get, you know, is the right thing? How do we know how to put together a bundle? And I think that remains a question. It'll come up as we think about other things. So as I was doing this work, I had, you know, an insight, and, you know, I was like, these events that we are interested in hazards of hospitalization, they are not unrelated, right? Like if and here was something I was like, we're giving our frontline staff, our nurses, others, like really conflicting advice. Like I may have a bundle for Foley catheter where it says put in a catheter, you know, or don't pull a catheter because you don't want to get infection, but I may be saying, hey, you cannot have a moist perineum, you know, put in a catheter because they're incontinent, right? Like how do you balance those risks? And this was one little model that we came up with when a nurse is faced with, should I use a Foley catheter? You know, what are the things that I have to weigh? Am I trying to maintain continence, and therefore I probably don't want to, and I don't want to do infection? Am I trying to reduce moisture? Is pressure ulcer the biggest risk here, and there's not another good way to do it? Or, you know, am I trying to reduce falls? And there's this counterintuitive, right? If I put in a Foley catheter, they don't have to get up, and most of our falls happen in the bathroom. And okay, you know, so then good, we won't have those types of falls. On the flip side, then they're stuck in bed, they're not moving as much, and then it contributes to hospitalization-associated disability. And are they then more likely to fall, right? So you've got all these competing risks, and I use that term specifically because you know, it's a modeling approach. But I was like, what is a nurse to do? You know, what are our frontline to do? What are we telling them? How can we make their lives easier? So I did a bunch of work right around the 2017, 2018, before I left the university, with Mark Greitz in healthcare policy research, Mary Beth Mackich, who's in the School of Nursing, Mustafa Özkaynak, who's you know, does a lot of digital and I'd say human factors when it comes to things like displays of information. Blaine Reeder as well, who's no longer here. But we did this work where we like we got data on all those three conditions from multiple. We had wasn't a grant, it was a contract from AHRQ, and we had data from, I don't know, 5 or 7 different health systems from their incident reporting systems, right, about falls and pressure ulcers. And we got and catheter-associated UTI from their surveillance data. And we created a model of, you know, when you know, someone was at high risk for these conditions, and whether or not, you know, it was, you know, prudent to insert a catheter or not. And we did a bunch of kind of, how would a nurse interpret this data, right? And so that was the focus of the work. And we published 2 papers from that. But ultimately, you know, having a nurse at the bedside having to assess, I think they're going to be at risk of having a fall in the next 2 days, and therefore this is what I should do with the catheter, right? It's just the amount of cognitive load was not necessarily going to be helpful. But it, you know, it just was when I started thinking about complexity. And this is where, you know, as I dove into safety science, right, thinking about complex systems. So here I have, you know, in my simple way of thinking about it, what what's a simple system, what's a complicated system, and what's a complex system, and what's different about them. So simple, this is, I use streets as this analogy. Simple, here's a T intersection on a country road, right? There's only one way in and two ways out, right? You know, but it's pretty determinative, right? You know, there's not much going, kind of judgment here unless another car is barreling down in the wrong direction. Complicated, I think this is a picture of like, you know, it may be I-25 and I-70. It used to be called the mousetrap, right? You know, and there's a lot going on in that middle picture. But basically, you know, if you get on one ramp, you know where you're going to end up. In fact, you're like, oh, shoot, I should have taken the other ramp because there's no way to turn around, right? Like, you know, the inputs determine the outputs in this system, even as complicated as it is. A complex system. So where do you guys think this picture is from? It's Paris, right? It's from the top of the Champs-Élysées, top of the Arc de Triomphe, looking down at the Place d'Etoile, right? And there's 11 streets that come into that space. And there are, I don't know how many lanes of traffic in the circle itself. I don't think anybody knows how many lanes of traffic. And somehow, like, you can't predict where any given car that's coming in, where they're going to end up. They eventually figure it out, right? Each individual driver navigates through that mess. But that's the difference between complicated and complex. Complex, and we use the term a lot, complex adaptive systems. But in these complex systems, right, you can't always write a model to predict exactly what's going to happen. You can write a model to predict the middle one. You can't write a model to predict the complex system. And, you know, things come with that. You know, I've seen talks where we talk about like schools of fish, right? It's a complex system. You know, there's not a leader in a complex system. But the fish all know, right? They have to stay close to the fish next to them and they have to swim forward, right? And you get, you know, a big school of fish that is, you know, important for survival, right? It makes it look really big. No shark is gonna go after that huge thing in the water. They can't, unless they can, you know, find a little trailing fish to pick up. So it serves a role, but it does, you know, it changes. It's not super hierarchical. It can expand. It can adapt to changing circumstances. And so when I think about, you know, that picture of the cascade of this disability and hazards of hospitalization, that's a complex system. So I think a lot about healthcare as a complex adaptive system. So I use this picture a lot. You know, we have this, you know, and this is just, I don't know, probably pretty typical OR, right? We have a lot of technology. We have all sorts of therapeutics. We have policies and protocols about how to interact in that space. And then we have a bunch of really highly trained people. And we have a patient on the table who may or may not respond to the therapy in the way that we expect, right? And so I say, you know, we want safe, reliable care. You cannot always predict. You have to create the system in which we try and, you know, we believe will get us to the outcome. And then we try and create resilience in the system to adapt to changing circumstances when things aren't going as predicted, right? So I need a good picture of an outpatient setting because I really do believe we have a lot of control over the OR, but in the outpatient setting, it may not be quite as highly technical, although we do technical stuff in the outpatient, but we have no control, right? We have very little control. And so you've got a patient and you've got to navigate them through the healthcare system, and you have to understand, you know, the social factors that are there, and, you know, interact with their family and whether or not they can get their meds. And so I do feel like, you know, we have a lot of complexity in all parts of healthcare. It's just easier to put in one picture. here for the typical OR. So, and I want to talk a little bit about resilience. And when I talk about high reliability, I talk about one of these, the properties of highly reliable organizations, which is resilience. So, property of a system that confers on it the ability to remain intact and functional despite the presence of threats to their integrity. And for general audiences, I'm a geriatrician, I'm going to use the geriatrics example. So these two people are both really doing great walking their dogs, right? One of them has more resilience. So when the dog sees a squirrel and takes off, right, she's going to be able to, one, hopefully not get pulled over. Two, although she might, but she won't suffer in the same way if she does, and run after the dog and step on the leash and catch them, right? He's going to have a harder time, right? So aging is essentially aging physiology, and is the final result is a loss of resilience, right? You just can't, you can't get your blood pressure up as high. Your pulmonary capacity isn't the same. Your muscle strength isn't the same, et cetera. So I like to describe resilience in general using a geriatrics example. But, an example in, I just kind of put this together, but emergency care, right? Emergency care has to be resilient, right? You have to be able to accept surges in capacity, right? We all know what a full waiting room is like. So and then you have to be ready for those challenging events. Here's a trauma bay at Denver Health, right? That you and you have to train for those events, and that creates resilience in the system to be able to adapt and to meet particular high-risk needs. So resilience is a really important thing. Our emergency management folks spend a lot of time thinking about this, but in all aspects of healthcare. All right. So for me, as I thought about this, to me, the fundamental challenge of geriatric hospital care is that we've got low resilience all around, right? We have a patient, the poor woman with the oval over her face under chair arrest, and who doesn't have a lot of physiologic resilience. And then we have a system that's not supporting that patient. So the system itself is pretty brittle, right? So, and one of the things over the last, I don't know, 10 years is really a rise of this idea of, or maybe even 15 years, the rise of this idea of, in safety science, of a flip because of what we know about systems and resilience, this idea of resilience engineering. And some people call this, safety one versus safety two. So I grew up in the area of safety one, right? I focused on decreasing the number of catheter-associated UTIs, decreasing the number of falls. As we shift the paradigm, a little less focus on that reactive, like how to, let's look at this event, let's do another RCA, let's find the root causes and fix that. Safety two challenges us to be more proactive. So what are the systems that we can put in place that would make us as successful as possible to have positive outcomes? How does normal work support those positive outcomes? And so to do that, you have to study how we normally succeed. So these things have really informed, I think, how I think about care. And so I'll just say a little bit about ACE units, because I think they, maybe are more in that safety two type of format. So the original paper on ACE units was from 1995, Bob Palmer, who I think was at the, Cleveland University Hospitals. And these were how the original paper described ACE units. So a prepared environment, a patient-centered assessment, medical care review, particularly medication review, but also, do we have the right, are we prescribing bed rest when we shouldn't, et cetera. Daily interdisciplinary rounds and early planning for discharge. And the original paper showed, improved ADL, shorter length of stay, lower hospital costs, and fewer discharges to institutions. This is right, amazing. when we created the ACE unit, here's an old picture. Dr. Kumbler's there. Denise was our social worker for a million years. Sunny, you gotta help me out with this. Dora's probably sitting behind the counter there on the computer. And then our resident team, our nutritionist is in there as well. But it turns out one of the nurses now works with me on the quality team at Denver Health, Emmy. So we created this model. It was similar to the ACE unit model, but probably the biggest difference was that we didn't have a different environment. It wasn't carpeted. We didn't have, kind of the modifications that you might for people who have sensory impairment. It was just a normal hospital unit. It happened to be a little smaller than some of the other units. But we, we spent, and it turned out to also be a great teaching model, I think. But we were very proud of this model of care. This is data from a review by Chad Bolt, who was at Hopkins at the time, on ACE units in general. Quality of care, I can't remember how he assessed that. Quality of life, functional autonomy, survival increased in 3 out of 6 papers, and use of health care services lower in 2 of the 8 papers. But, generally really useful outcomes. So the problem was that, how many ACE units are there around the country? Not that many. And where they were, they ended up being in academic centers, right? So there was a teaching model and places where you had geriatricians who were willing to do that. Actually, listen, we had hospitalists that were willing to learn and be part of that care and part of that teaching model. Dr. Stephen Slapsley, hi. And so we had a lot of success here. We continue to have success here with that model, and the implementation of it, wasn't super. It wasn't like wildfire. And people would say, "Well, why do we have an ACE unit? Why can't we provide that care for everybody?" Well, I'm like, well, clearly, we don't provide that care for everybody, and it is hard. And so I remember putting together this years ago, what if we had a standard, thinking in the infection prevention paradigm, right? What if we had standard precautions for geriatrics, right? You could, safe mobility, orienting communication, bright lights in daytime, uninterrupted sleep. Here's our standard precautions for geriatrics. We never quite tried to do this, but there have been lots of different studies of models where they try and push ACE unit concepts out to every patient. So the ACE tracker guy, Mike Malone, who was in the Midwest somewhere. He was a doc, and he would do almost virtual geriatrics consult because he had a data feed from all of his hospitals, and he would see their mobility score and their fall risk score and their whatever other assessments, and then he would call them and round with the nurses and give, so he was like a remote consultant. And another model from Melissa Madison, who was at probably Beth Israel at the time. And then, and there's a guy in Australia who I've visited in Brisbane named Len, whose last name I can't remember, who was the geriatrics virtual consult doc. He would do consults out to nursing homes in the outback, right? He was the one geriatrician for thousands of miles. So anyway, there have been attempts to do this. So I'm going to ask you to kind of hold that thought as I go into another thing. And so as I was thinking about going back to this model and the limitations of what I was doing in my research life is just focusing on one vertical here, then you focus on one vertical there. I started to think more about the horizontals. How do I focus on the horizontals? And that hazards of bed rest and hospitalization came up. And so this was the title of an opinion piece I wrote in JAGS, The Geometry of Patient Safety. And I feel that way a lot about quality improvement in general, right? That we can go, there are times we need to go vertical to, stomp out the SSIs that we're seeing pop up, right? There's specific something that's going on, and there are times, but in general, horizontal is going to have an impact on a whole bunch of different outcomes. And so we started to think about that a bit more. And at this time, I was chair of the Quality and Performance Measurement Committee at AGS. I was kind of the only academic on that committee. It had been handed to me by Caroline Blum, who was like this kind of really amazing person in the quality measurement space, and a health services researcher who's now at NCQA. And we were like, what we would do is like the government or one of the quasi-governmental agencies would come out with a paper of like, or a suggestion of like, these are new quality measures. And we would then spring into action this committee and we'd review the quality measures and we'd say, but could you consider this? This is not good for geriatric, like diabetes, measures of hemoglobin A1C less than, 6. And we're like, no, not for our geriatrics patients. So we would try and put a geriatric review to all of the quality measures that were coming out. But we wanted to be more proactive. And so we decided we were going to, pick a topic and do some work on it. And the team came up with this idea of mobility in the hospital. And so we ended up over the period of a couple of years doing a huge labor of love, right, to put together this white paper on mobility in the hospital. So our goals were to discuss the implications of low mobility, review the measures in particular and the interventions, and make recommendations to move the field forward, particularly in promoting routine assessment. And so these were the recommendations. This was like, took 2 years to do this literature review and, kind of come up with what we wanted to do. But these were the recommendations that came out: promote mobility assessment in acute care, advocate for more research funding, develop consensus on methods to assess mobility, minimize burden of mobility measurement, evaluate feasibility of quality measure and mobility, and this was really important, reframe the focus on fall prevention, right, to a focus on safe mobility, and develop resources for acute care clinicians. So this came out in 2018. It was a white paper on the website for JAGS. It also was published, like an executive summary was published in JAGS itself. And then we did, a bit of a workshop at AGS. We had all these great folks from different organizations who were doing great mobility work join that. And I kind of thought that was done. And this was when I actually left the university and went to SCL Health. So here I'm kind of newly at SCL Health, and I'm learning, a whole new job, right? So I'm moving into the chief quality officer role. And it turns out that I happen to have on my team, in addition to the patient safety, I had the workforce safety work. And I happen to have this spectacular physical therapist, Nancy McGann, and I don't know if Nancy made it on here, but who was our lead for safe patient handling. So these are the folks that help train our frontline staff about how to safely move patients to avoid injury, how to use all of that assistive equipment, et cetera. And Nancy came to me and she was like, "You're Dr. Wald. You wrote that paper. That paper has like changed the field of safe patient handling." I'm like, "What are you talking about? What do you mean?" She's like, "You're kind of famous in our field. And what can we do together?" And this is what she suggested to me. I don't think this white paper was the only thing. I will not take credit for that. But there was kind of this area over here, safe patient handling, that was focused on reducing injury to our workforce. They were not focused at all on patient outcomes. And then we had this, crazy focus on fall reduction. And I'll say crazy obviously want to reduce patient injury. But I have sat in board meetings where I've had to explain to board members, they'll be like, "Oh my God, are we still working on falls?" And my answer is, hey, guess what? Falls are part of the human condition, right? We are always going to be working on falls. Our job is to, not really harm people when they fall, make sure that, I really focus on the harmful falls and the ones with major injury, but that, and to be, but we have to be getting up and moving people, and therefore, 0 falls ever is probably not the right way to think about it. And then this was around the time that really people started talking about safe mobility rather than fall prevention and safe patient handling. And those two started coming together, which really reduced disability all around. And so we embarked on a bunch of work at SCL Health in this space. And in our last couple minutes, I'll share about that. So SCL Health, based in Broomfield, 8 hospitals in Colorado and Montana. The 5 in Colorado, the one you would know the best is St. Joe's, but also Lutheran, Good Samaritan, Platte Valley, and then St. Mary's over in Grand Junction. So those were the local hospitals. And as chief quality officer, I had the ability I had a small grants program, similar to what we have had here at the university. From our risk management, our risk mitigation, we have a pool of money to reinvest in more risk mitigation. And so we were able to fund a whole bunch of things with that money, but in particular, we funded a series of grants at SCL Health, led by Nancy McGann, who was leading our Safe Patient Handling program and then our Safe Mobility program. Also, really important partner was our Chief Nursing Officer, Lori Whiteman, who said, yes, let's do this. Let's marry these efforts. Because, right, this is, the nursing is the biggest workforce, and they're implementing these things, and we're making it hard for them. Some things that were really helpful when we first started this work was we decided not to use mobility techs. There are some health systems that would invest in mobility techs. We're like, oh my God, every other year we're in a funding, we're cutting positions, whatever. We don't want something that's just going to be so vulnerable to whatever the financial wins are. And so we wanted to really use our nurses. And they are a burden, but we had a lot of support because they felt like this is what we do, right? This is good nursing care. And then we had already rolled out the BMAT, the Banner Mobility Assessment Tool. That's a tool that we would use to determine what type of assistive equipment, what's the level of mobility, and then what type of assistance does the patient need. So we had that in place, and that was really helpful. So this was the first set of grants, and you can see the timing of this wasn't perfect. So the first pilot was maybe a little stop and start, but we did a pilot on 2 floors. These were, I think, at Lutheran, MedSurg, the old Lutheran, not the new building, but MedSurg and adult ICU. We targeted adults greater than 65 with a high BMAT. So here's the BMAT, and I'm, there are others in the room that will know that better than I do, but we did a high BMAT. So it was basically you passed the BMAT 3, but you couldn't quite get to the 4, the level 4. I'm sorry, you didn't. I stated that wrong. You could do, it was level 4s were in there, and then level 3s who passed level 3 but just couldn't get to level 4. So we kind of divided level 3s in half. And we asked our nurses to do therapeutic ambulation 3 times a day. That was the goal on all of those patients. And when we got proof of concept with that, in 2021, we funded another, and these grants are like $30,000. This is not a lot of money. This is to bring together, a bunch of people in Broomfield for a conference, right? To get together and learn together, to bring in, some food, to fund somebody's time to go to a training event, et cetera. So we did all across all 8 of our hospitals. That includes, St. Joe's, a community large complex teaching hospital, and, Holy Rosary Hospital in Eastern Montana, a small critical access hospital, right? So we had array, and we across all adult inpatient units, and we included all adults over 65 admitted for at least a day. we did great stuff, right? We got our patients moving. So this is something I guess we put in front of the board. This is, I had to get permission to use, this is not published data from Intermountain. So our target was 25% of patients our entry goal. Our target was 5, and our stretch was 40% of patients, and that met those criteria were to have 3 times a day therapeutic ambulation. So you can see 2021, we weren't quite there, but by 2022, most of our hospitals were above entry, and some were really excelling. And then by 2023, every hospital was above entry on that goal. And with regard to 1 time a day therapeutic ambulation, like we were knocking it out of the park across all these hospitals. And these rows are each of our 8 hospitals, and then the overall. So just our abbreviations that we would use. And this is just this is like cumulative number of patients that we got moving, right? So over time, and it really increased year over year. And this is a breakdown again, by the hospital's peaks. Once we became part of Intermountain, this region was called the Peaks region. You had to know your geology really well, because the Utah was known as the Canyons region, and then Southwest Utah and Nevada are the desert region. So we were the Peaks region, but you can see that, we started probably pretty typically, and over time really met our target goals by 2023 and keeping people moving. We also then, encouraged by this, we started to do mobility work for people who were pre-ambulation, so that if you were BMAT 1, 2, or low 3, so I told you we split the BMAT 3s in half. So we also did, we had prescribed activities that we wanted, things like Q2 turns and passive activities. One of the things we learned from all of this work, really, but particularly in this work, was that if the PTs are documenting over here with the OTs, maybe they have shared documentation, but nursing documentation is different, then we have silos. And so we brought together everybody now across Intermountain documents in the same place. So it's one documentation of mobility. A word about this, because we're super proud of this work. I'm sure you all had folks doing similar work, but we, because of the disruption of COVID in the summer of 2020, we gave an emergency grant to this team to do proning improvement work. And this was spectacular. So, and Nancy, again, brought together all of our folks who, across the hospitals who did, involved in the proning process. And everybody thought they had the best way of doing it. And they got together and they did a simulation day. And some people, took turns simulating as the patient. And they would turn each other and with the different equipment. And they ended up with a process that was a combination of lifts and some friction reducing devices. But they managed, I think the big thing was that they managed to reduce the number of people needed to prone in half. So it was 6 people originally, right? These are like people in the ICU on vents. They used to take 6 people, they got it down to 3 people, and they also reduced the time significantly. But they also reduced, so you can see the minutes to prone per patient was like, chopped. And then they reduced facial pressure ulcers, and all pressure ulcers. So it was incredibly impactful work. And guess what? When you reduce the amount of friction reducing devices, you also save a lot of money. They cost a lot of money. They're single-use devices. And so we submitted it to this journal, Patient Safety and Quality in Healthcare. It's a kind of a throwaway journal, but we got a national award for that work. And then as we merge with Intermountain, and Intermountain has a hospital, a Latter-day Saints hospital in Salt Lake City, LDS, that was like known nationally for work in early mobility and ICUs. And so we were really like, okay, now we've got to move on that. I think we did really, we've done a lot. At St. Joe's and Lutheran was where we focused. Those were our kind of biggest ICUs. Although I think that COVID work on proning was a particular success factor there because they, you know, the RTs and the nurses, and they kind of had all, you know, figured out how to work together. And we saw large, in those two hospitals, we saw large throughput and financial impact. And this is, you know, a lot of this is since I left that organization, but the half-day reduction in ICU was consistent at both hospitals, but even at St. Joe's, almost a 2-day reduction in total length of stay from related to that work. One last thing that we did was really push SCL Health and then Intermountain on ceiling lifts. So we made a push that for every new construction or major renovation, that ceiling lifts would be factored in. This is such a win-win-win. And here's just some learnings from that work, that you had to have universal coverage in everywhere except for like pediatrics, you don't need so many lifts. But you know, for acute and critical care, because nurses have to get it in their workflow. And if you have to move the patient to a different room for the one bed that has a lift, like you're not gonna, it's never gonna happen. And then you needed a program to support the nurses in doing this work. There's a whole bunch of other things that we learned, but bottom line is that the investment pays for itself in 3 years with workers' comp claims, right? And think about, with our aging nursing workforce, keeping them in the workforce longer is super important. So really proud of this work as well. And Intermountain now has this spectacular safe mobility program. Every patient has a safety and mobility plan. So we have the BMAT score. For the falls, we use a modified Morse that I don't have time to talk about as well. And so every patient has posted in their room their maximum activity level, what safe patient handling tech they require, and their activity goal. And based on these assessments, and then we have a singular, they now have a singular dashboard across the whole organization where we can see like who's, you know, what areas of the health system they need to work on, and also, you know, how we're doing. And so I hope they have many opportunities to publish many great things from this work. 4 minutes. Okay. Age-friendly health systems. My thoughts. So, you know, getting back to this idea of like, how come we can't spread this work everywhere? So I think, you know, the folks who developed age-friendly, you know, had really, really great intentions and really great way of going about it. They picked 4 areas that they thought were going to be sticky. There was good evidence. And again, we don't know, this is this bundle idea. We don't know how all these things actually work together. It hasn't been studied incredibly well like that, but it was more on the idea of face validity, right? Unfortunately, because fortunately and unfortunately, when working with the IHI, they have a framework that they call the tight, loose, tight framework. So everybody has the same goals. There's a lot of loose in the implementation part, how you're going to do it in your organization, and then you're looking at the same outcomes. I would say that, therefore, when somebody says they're age-friendly at a hospital or a health system, you have no idea exactly what they're doing. I think there's probably a lot of people who claim we're age-friendly, and you know they can check off some boxes for CMS and the new measure, et cetera, but they're really, like, they may say they're doing the 4 M's, but they're not doing mobility the way that Intermountain is doing mobility, right? You know, they're like, yes, our nurses do the BMAT, and what does that mean? You know, so I think that you get a lot of pretty lackadaisical implementation, but they did do a spectacular job of creating a movement and getting it in front of policymakers. Those are just kind of summary here. There's a lot of study to be done. And so to my point about implementation across the VA only has resulted in 4.4% of older veterans with all 4 M's documented. And the VA put a lot of money into this. And Bob Burke, who used to be at this organization now at Penn, has done a lot of the VA evaluation work. So anyway, with that, when I went back and thought about my patient and then the questions that I asked all those years ago about what would I've done differently, I might actually ask different questions. Should we have assessed and implemented a safe mobility plan for this guy? Should we have understood what matters to the patient as we were creating his care plan? Should we have been more thoughtful about his mentation and delirium risk? And should we, again, ensure safer and more judicious medication prescribing? So there you go. Thank you so much for your attention.
For one question.
Okay.
We have a question. Okay. Great.
Yeah. Wow, that's interesting because I don't know that that's been an issue at Intermountain. I have to ask Nancy, but I mean, we put fall risk stickers on the door all the time and code sticker, like we have ways of indicating. And you know, I think you have to push back on that, right? It's central that the patient, their family, and the staff know as part of the care plan. But yeah, yeah, I think you do need the specifics, and I think it's an interesting question. I can ask if they have run into that, but you know, yes, you can say Intermountain is doing it. You know, they're the big, you know, elephant over there. You know, if they can do it, and we have used that at Denver Health. UC Health is doing it. We can do it. We're in the same legal environment, et cetera. So, yeah. Yeah.
Heidi, other questions, and thank you so much, and have a wonderful